Hello and welcome to Health Chats with Abington Health. I'm your host, Lu Ann Cahn with Philadelphia Magazine. This web chat is sponsored by Abington Health in partnership with Philadelphia Magazine. Our topic tonight is getting pregnant after the age of 35. And we know this is a very hot topic because so many couples and women are deciding to get pregnant at a later point in life. So we hope tonight that you're going to learn about fertility, assistance options for getting pregnant, the risks and benefits for getting and being pregnant later in life. Tonight, we're chatting with Dr. Mara Thur, OBGYN at Abington Health. Good evening, Dr. Thur.
Hi, Lu Ann. It's nice to see you.
It's nice to see you, and thank you for joining us. Before we get started, I want to remind everyone at home that if you have questions during our discussion, you can ask them in the text box right under the video. So don't be shy. This is anonymous, it's confidential, so feel free to ask us whatever you want. And also, please feel free to encourage your friends to join us. You can they can log on anytime during the chat by sending a link. You can send them a link to Health Chats and share that, send them an email or share it on social media. Okay, Dr. Thur, first, before we get started, why don't you tell us a little bit about your background and your expertise?
So I am an OBGYN at Abington. I've been there for 13 years. I did my training there, and I went to medical school at Temple. So I'm a generalist at the hospital, and I see everybody from age 13 to age, into their 90s. So sort of run the gamut: obstetrics, gynecology, a little bit of everything.
We were talking a little bit earlier, and you were saying that in a way when couples are trying to get pregnant, if they're having problems, you're kind of a gatekeeper. Can you explain that?
Well, we, as a gynecologist, we're the primary care doc for a lot of women. So they come to us for their yearly GYN exams, and certainly when you're into your 20s, your 30s, your mid-30s, this is kind of the hot topic, getting pregnant. It's always on their mind. And if you come to us and are having difficulty, I can certainly start the process of doing that workup if someone's having trouble getting pregnant. And then once we've taken that road for a period of time, and if we haven't been successful, then I can refer someone off to an infertility specialist.
Okay, we have received so many questions in advance, and one of the most basic questions is, okay, you want to get pregnant, what are some things you should do before you even start trying?
So I think generally you want to lead a healthy lifestyle, just like anything else. And you want to make sure that you optimize your weight, that you're eating a healthy diet. And most importantly, we think about things like folic acid, which is oftentimes things that you get in your diet, but it's certainly something supplemental that we would want you to take before getting pregnant. We usually recommend that you take either a multivitamin or a prenatal vitamin for at least 3 months before trying to get pregnant. We want those things on board, and particularly the folic acid, to help prevent against neural tube issues.
So I want to move to the topic of fertility, more questions about that. A lot of women would like to know if stress impacts fertility.
It's interesting. There's been a lot of studies that look at this, and sort of anecdotally, you would think so. If you lead a very stressful lifestyle, you produce a lot of hormone called cortisol that maybe it decreases your fertility. There's definitely some people say yes, some people say no. It's sort of a little bit of the issue with trying to tease that out is that there's so many other factors besides just stress. And so it's a little bit, it's kind of a question mark as to whether stress really does affect fertility. You know, it's interesting. We were talking about this before we started, that you hear a lot. There'll be couples that have been suffering with infertility for a long time. You know, they finally make the decision to go for IVF and they get pregnant, they have a baby, and then they come to us and they say, you know, oh, I don't need any contraception now that I've had this baby. You know, I've had all of these years of infertility, and then, you know, the stress is gone. They're, you know, wonderfully happy with their new baby, and then poof, all of a sudden they're pregnant and they don't even realize it. So you've got to wonder whether stress does play some sort of a role.
So there are so many more options if you're having trouble getting pregnant. What are those options?
So I guess to back up a little bit, when someone comes to us with issues with infertility, we always start out with a complete history. We want to know kind of what your past is, whether you've had any kind of prior pregnancies in the past, what your partner's pregnancy history is. And so you start with a pretty thorough history. And then we do a little bit of blood work, a little bit of baseline testing, just to make sure that all of those things are normal. And then once you've sort of established that all the parts are working, we often recommend that the husband gets a semen analysis, because really, when you talk about infertility, about 40% of the time it's a problem with the man, about 40% of the time it's a problem with the woman, and about 20% of the time it's an issue with both. So even though we focus so much on infertility and having it be the woman's issue, in fact, almost half the time it's an issue with the male partner. So once you've kind of gone through those that testing and you've sort of gotten to the point where everything looks like it checks out okay, then for me as a generalist, a lot of times we can give oral medication to try and help you to ovulate. And that tends to work really well. You know, oftentimes we'll give people several cycles of a particular medication, either a medication called Clomid or another medication called Letrozole. They're easy, they're inexpensive drugs that I can give in the office. And then I basically tell people, you know, go have fun. You've taken your medication. You plan to ovulate at this particular time. Enjoy yourself, and then we'll have you come back and see if we've been successful at getting you pregnant.
How long should they wait? Let's say you give them oral, you give a woman oral medication and nothing happens. How long do they wait before they come back and say, okay, we've got to go to the next step?
So, yeah, everyone's a little bit different. You talk to sort of general OBGYNs and they might have a slightly different approach, but at least for me, I probably give someone maybe 3 cycles of the medication, because it isn't, you know, I joke that I just tell people to go off and have sex. It's not really like that. There's some monitoring. You know, I tell them exactly when to take the medication. Then, you know, they'll go and do what's called timed intercourse, meaning that we tell people to have sex every other day, right around the time they're going to ovulate. And then, you know, they are either pregnant or they're not. And then they'll come to me, you know, I've got my period, Dr. Thur, and then we might try another cycle of that same medication. And then once we get to that point and I've sort of exhausted my means, then I would refer out to a reproductive endocrinologist, an infertility specialist.
If oral medication isn't working and you refer them to a fertility doctor, what might a fertility doctor offer? So the fertility doctor oftentimes will maybe repeat some of the blood work that was done by the generalist, and sometimes they can use oral medication as well. The advantage that the infertility specialist has is that they have ultrasounds at their disposal. Their laboratory is usually very, very accessible, and they're able to monitor patients a little bit more closely than I am. I don't have the luxury of having an ultrasound in my office where I'm able to monitor those people. So oftentimes the fertility specialists will use those means as well. So if those don't work, then oftentimes there's injectable type medication, although fertility doctors seem to be moving away from that because there's a lot of complications. It's a lot harder to control those. So then
and they move on to IVF. And now even IVF has become very controlled. Oftentimes there's not the same risks of twins and triplets and quadruplets and things like that.
And doctor, if you would explain IVF, what is the basic process?
Sure. So IVF is in vitro fertilization, and the woman is given medication in order to stimulate her ovaries to produce eggs. So the eggs are retrieved, and then the husband or the partner then contributes their semen. They make an embryo in the petri dish in the lab, and then they go ahead and implant those embryos back into mom. It used to be that they would maybe implant 2 embryos, 3 embryos. It really depends. There's a lot of variation in that. But just in talking to some of the infertility specialists, recently they're trying to cut down the number of embryos that they reimplant, because the success rates are so high with just 1 embryo, that they're trying to limit the amount of twins and triplets and things like that.
Let's continue to talk about risks, because there definitely are risks having children later in life to the mother and the baby. Can you talk about that?
Sure. So there's risks to mom during pregnancy. When you are over the age of 35, there is an increased risk for diabetes, for high blood pressure, issues with the placenta, and so those are some of the things that we think about and we monitor older moms for during the pregnancy. So particularly women that are over the age of 35 into their 40s, oftentimes we do additional ultrasounds to monitor the growth of the baby, because sometimes the placenta just doesn't function as well when you're as you age. So that's certainly an issue for pregnancy when you're over the age of 35, just for maternal reasons alone. And then, of course, when you talk about an older mom, there is that increased risk for genetic abnormalities. And so there's a lot of options in terms of getting genetic counseling and what genetic testing is available to kind of find out more about the pregnancy.
You know, I think you mentioned earlier the risk of gestational diabetes, and you know, why is that more of a risk, and what happens? What is gestational diabetes, and what happens if you have that?
So gestational diabetes is basically diabetes that occurs in pregnancy. And some people come in to pregnancy already as diabetics, and they're in a completely different situation than a gestational diabetic. So normally in pregnancy, we would check someone for gestational diabetes between about 24 and 28 weeks of pregnancy. They drink a sugar drink and then get their blood taken an hour later. And depending on how they do on that screening test, if they fail it, they then move on to something called a 3-hour test, where they drink the drink and then get a series of blood tests done. If you are diagnosed with gestational diabetes, oftentimes we recommend a diabetic diet. And most people do very, very, very well on that, and their sugars are controlled with diet. They don't need anything further. Sometimes even despite people's best efforts with exercise and with eating the proper diet, their sugars aren't well controlled, and sometimes need to go on either oral medication or sometimes even injectable insulin.
Is that any predictor for whether that woman would get diabetes, or it's completely unrelated?
No, it is predictive. There's probably about 15% of women that have gestational diabetes then go on to develop diabetes when they're not pregnant. So in those cases where someone's diagnosed with gestational diabetes, oftentimes we'll recommend a follow-up test, usually 6 to 8 weeks at least postpartum, where we have them do a similar drinking that sugar drink and then getting their blood taken to test for diabetes. It's called a 2-hour glucose tolerance test, which we do postpartum.
Dr. Thur, we're going to be wrapping up our health chat in a few minutes, and I thought maybe we go back and just review, if you're telling someone who's over 35, who's thinking about getting pregnant, again, what do you think are the most important takeaways for them?
I mean, I think that your approach to getting pregnant should be the same as if you were younger. It's just your, that proverbial biological clock is ticking. And so it's not something where I would tell people to, attempt to try for, a year or 2 years on their own. And if they're not successful, I would come to see their OBGYN earlier so that we could start the process of the workup to see why they're not getting pregnant. And then, from there, once they are pregnant, just being aware of what's offered in terms of genetic testing and things like that to make sure that the pregnancy is healthy.
Dr. Mara Thur, thank you so much for being with us tonight, and we thank all of our viewers for joining us for this health chat that's sponsored by Abington Health in partnership with Philadelphia Magazine. And I want to tell you to find more information on your specific health questions. You can go to www.abingtonhealth.org to find an Abington Health Center or hospital near you. On behalf of Abington Health and Philadelphia Magazine, I'm Lu Ann Cahn. I hope you have a wonderful evening. Thanks for joining us.